Let's jump right into high-yield GI decision logic. We're moving anatomically top-down today, from the esophagus down to the colon, to really lock in these clinical presentations for your exams and the wards. We're going to compare achalasia against mechanical obstructions, differentiate secretory from osmotic diarrhea, and contrast Crohn's disease against ulcerative colitis. Let's get straight to the core diagnostic steps. Section 1. Dysphagia and esophageal motility. So the absolute first step in evaluating dysphagia is strictly separating trouble initiating a swallow from the sensation of food sticking after a swallow has already occurred. Oropharyngeal dysphagia presents with your patient coughing, choking, having aspiration events, or even experiencing nasal regurgitation right as they try to initiate that swallow. Since this is a structural and functional issue up in the upper pathway, you evaluate it with a videofluoroscopic modified barium swallow to watch the actual mechanics of the throat. On the flip side, esophageal dysphagia means the initiation is totally fine, the food is already down, but it feels like it's just stuck in the chest. For esophageal dysphagia, establishing the symptom chronology is your golden key. You have to ask about timing. If a patient reports trouble with both solids and liquids right at the onset of symptoms, that points straight to a motility disease. The muscles just aren't working right to propel the bolus. But if they report progressive difficulty with solids first, which later evolves into trouble with liquids, that flags a mechanical obstruction. In that case, you want to be thinking about a growing cancer, an esophageal stricture narrowing the lumen over time, or other mimics like Schottky rings and esophageal webs. Now, when that concurrent solid and liquid presentation makes you suspect a motility disease like achalasia, you need to know the preferred test. The most accurate diagnostic test here is esophageal manometry. It directly reveals the mechanism. You'll see a high lower esophageal sphincter resting pressure combined with incomplete relaxation of that sphincter when the patient swallows. You absolutely must identify these specific pressure changes to confirm your diagnosis. Following the workup logic from symptom onset helps navigate when to use barium swallows versus manometry. But remember, even if you suspect a motility issue and order a barium swallow or manometry, you often have to jump to an upper endoscopy to rule out pseudoachalasia caused by an underlying malignancy. For instance, Chagas disease or tumor right at the gastroesophageal junction can completely mimic achalasia. So an endoscopy is crucial, especially if you're seeing weight loss or an acute onset in an older patient. Let's test this with a quick clinical vignette. If you see sudden onset adenophagia, meaning painful swallowing, coupled with retrosternal pain, and an endoscopy shows a discrete ulcer right in the mid-esophagus, your target diagnosis should be pill-esophagitis. The mid-esophagus is a prime spot for this due to compression by the aortic arch or an enlarged left atrium holding the pill in place. That leads to direct mucosal injury. Moving on to Section 2, GERD complications and management. The crucial point here is understanding the underlying mechanics. GERD is driven by decreased lower esophageal sphincter tone, frequent transient relaxations, or an anatomic hiatal hernia. Risk factors like obesity, pregnancy, smoking, and alcohol directly exacerbate this. Manifestations include your classic heartburn and acid regurgitation, sure, but don't forget the extra esophageal signs like cough, hoarseness, wheezing, and importantly, odenophagia when erosive esophagitis is already present. This persistent acid exposure sets the stage for severe complications like strictures, asthma exacerbations, laryngitis, and the premalignant Barrett's esophagus. Keep in mind you do not perform an upper endoscopy for typical uncomplicated GERD symptoms. Reserve the scope strictly for critical alarm symptoms. These include dysphagia, odenophagia, unexplained weight loss, iron deficiency anemia, hematemesis, melena, persistent vomiting, or high cancer risk features. Weight loss and anemia are particularly important as they point directly toward an underlying malignancy or chronic occult bleeding, which demands immediate direct visualization. For uncomplicated cases without those alarm features, the management logic dictates starting with lifestyle changes. Think weight loss and dietary modifications coupled with an H2 blocker or a proton pump inhibitor. If the patient fails a trial of PPI therapy, or if they present initially with any of those alarm features we just covered, then you bypass the medical trial and move directly to an upper endoscopy to evaluate for complications or cancer. Section 3, dyspepsia, PUD, and ulcers. Dyspepsia clinically presents as epigastric pain or burning, postprandial fullness, early satiety, or bloating. When you see this, you need to clinically distinguish between peptic ulcer disease, driven by NSAID use or H. pylori infection, versus medication-induced dyspepsia, functional idiopathic dyspepsia, or a hidden malignancy. To add an extra layer of depth for the wards,
Remember to contrast the presentations. A gastric ulcer typically worsens with eating, while a duodenal ulcer generally improves with eating.
The decision logic strictly separates high-risk from low-risk patients based on age and presentation. For low-risk patients under 60 with zero alarm features, use non-invasive testing for H. pylori. Treat if it's positive and trial a PPI if it's negative. But if the patient is over 60, a heavily tested threshold, or if they have high-risk features like dysphagia, weight loss, or anemia, direct them immediately to an upper endoscopy. Let's shift to a critical inpatient scenario: stress ulcers in the ICU. Watch closely for painless, occult, or gross GI bleeding in these vulnerable patients. You must initiate PPI prophylaxis if you identify high-risk factors. Single factors requiring prophylaxis include coagulopathy, mechanical ventilation, severe head or spinal trauma, major burns, shock, sepsis, and high-dose steroids. These stressors severely compromise gastric mucosal blood flow, which rapidly leads to ulceration if unmanaged.
Section 4. Chronic diarrhea and malabsorption.
The critical differentiator here is the stool osmotic gap and the patient's response to fasting. Secretory diarrhea is driven by increased secretion of ions. It persists during sleep and fasting, and it features a low stool osmotic gap. Osmotic diarrhea, however, occurs because unabsorbed osmotically active agents are pulling water right into the gut, like what you see in lactose intolerance. This actually improves with fasting and presents with a high stool osmotic gap. Regardless of the gap, always screen for red flags indicating organic disease. Those include age over 50, nocturnal symptoms, fever, weight loss, rectal bleeding, abnormal labs, elevated inflammatory markers, and a family history of colon cancer or inflammatory bowel disease.
When you're dealing with malabsorption, use stool volume to help localize the lesion. Large volume diarrhea points to small bowel disease, while frequent small volume diarrhea suggests colonic pathology. Furthermore, if you see steatoria, those bulky, foul-smelling, floating, greasy stools, that firmly points to fat malabsorption. The differential for this includes pancreatic insufficiency, bile salt problems, small bowel Crohn's disease, celiac disease, giardia, Whipple disease, or small intestinal bacterial overgrowth, also known as SIBO. SIBO is an overproliferation of colonic-type bacteria up in the small bowel and is often a complication of altered anatomy, like a prior gastric bypass.
Section 5. Celiac disease and IBS. Celiac disease is a gluten-triggered autoimmune injury to the small bowel characterized by villous atrophy. Patients present with foul-smelling greasy diarrhea, bloating, weight loss, iron deficiency anemia, osteopenia, neuropathy, fatigue, poor growth in children, and sometimes an intensely itchy rash called dermatitis herpetiformis. Your first-line test is the IgA anti-TTG or anti-endomysial antibody. But here's the major exception to remember. You must strictly switch to IgG-based testing if the patient has concurrent selective IgA deficiency, otherwise you risk a false negative result. The treatment is a lifelong gluten-free diet. Diagnosing irritable bowel syndrome requires recurrent abdominal pain at least 1 day a week for 3 months, specifically related to defecation or a change in stool form or frequency, and it completely lacks any alarm features. Treat the specific subtype. Use antispasmodics for the pain, soluble fiber and osmotic laxatives like PEG for constipation, and loperamide or bile acid binders for diarrhea. Additionally, consider tricyclic antidepressants, especially for IBS-D. Keep in mind that patients presenting with diarrhea-predominant IBS must be screened for celiac disease because the presentations heavily overlap. Section 6. Inflammatory bowel disease. Let's directly map the transmural skip lesions, strictures, fistulas, and small bowel involvement of Crohn's disease against the continuous colonic mucosal disease of ulcerative colitis. Crohn's can involve absolutely any part of the GI tract and is significantly worsened by smoking. Ulcerative colitis, on the other hand, typically starts at the rectum, features prominent hematochezia, carries a severe risk of toxic megacolon, and mild cases are managed primarily with 5-aminosalicylic acid agents like mesalamine or sulfasalazine. Lastly, active IBD poses a significant risk for severe flare-ups during pregnancy. If you see an IBD patient who is pregnant or planning to become pregnant, carefully managing their medications to maintain remission is absolutely critical, as active disease can lead to adverse pregnancy outcomes. Make sure to keep this complication at the front of your mind for exam scenarios, and you'll be well prepared for any GI questions that come your way.